Hi, my name is Monique Ramirez, and this is my presentation on the COPD management, a team-based approach. The interdisciplinary team is consisting of Director of Pulmonology, pulmonologist, nurse coordinators, and support staff such as nursing leadership, clinical staff, social work, case management. This presentation is intended for the nurses that provide direct patient care to the COPD population. The reason why this is important is because the COPD population has a high rate of admissions due to exacerbations. The hope is that we can provide you with the resources, information, and knowledge to better understand this patient population and to address their needs during their inpatient or outpatient setting. The purpose of this in-service is to make sure that nurses are educated on the care coordination of the COPD patient population so that they may receive quality patient care. The outcomes are to familiarize yourself with the basic patient information of the COPD population and to know what the nursing role is in the care of these patients and to understand the national standards of care. This in-service is mostly for nurses providing direct patient care in the outpatient and inpatient setting. The outcomes are measurable through a post-test after the presentation, and the outcomes are obtainable by the end of the presentation. The learning outcomes do address the goal for the presentation, and by the end of the presentation, team members will be able to know basic demographics, to know the gold standards for the care of this population, to have a knowledge on the available resources for the care of this population, and to have a better understanding of the COPD population. Listed on this slide are the brief demographics that compose the COPD population. I will go through them briefly. 65 to 75 years of age, non-Hispanic whites, can be unemployed or retired, patients with less than a high school education, lower socioeconomic status, divorced, widowed, or separated, and one of the biggest ones is current or former smoker, and a past history of asthma. National standards of care have been set forth by the Global Initiative of Obstructive Lung Disease. The treatment is based on their COPD stage and spirometry results. To the right, we see the spirometry table, and the disease is broken down into 4 stages: mild, moderate, severe, and very severe. They use the FEV, which is the forced expiratory volume. They use that measurement to decide which stage of COPD the patient is in. To the left, we see the national standards by stage. So in stage 1, there's a lot of risk reduction such as smoking cessation and also prevention such as the influenza vaccine and a short-acting bronchodilator for symptoms. In stage 2, we see stage 1 interventions in addition to long-acting bronchodilators and a referral to pulmonary rehab to get those lungs back. In stage 3, we see stage 1 and stage 2 interventions, as well as the addition of glucocorticosteroids, again for symptom management. In stage 4, we see stage 1, stage 2, and stage 3 intervention with an addition of long-term oxygen therapy for symptoms as well, and also a possible consideration for surgical treatment if the patient's quality of life is severe and is a candidate for surgical treatment. Health promotion and risk reduction goals are to eliminate or reduce the risk factors associated with COPD. The 3 of them listed here are smoking, indoor and outdoor air pollution, occupational dust and chemicals. Smoking is one of the biggest ones because it's preventable and it can be controlled through tobacco control programs and smoking cessation programs. One of the strategies used in the hospital setting is to ask, advise, assess, assist, and arrange. We want to make sure we get a full assessment of the patient's smoking status by asking them if they smoke and documenting it into our medical records system. We want to advise against smoking and educate on the potential harmful effects of smoking, and we want to assess their willingness to quit. If they are willing to quit, we want to assist them in pursuing those goals, and we want to provide them with the resources that we have to help them meet the cessation goals. We want to also arrange follow-up, as follow-up is really important to help reinforce our smoking tobacco cessation programs. Our indoor and outdoor air pollution can be accomplished through public policies such as the vehicle emissions, as well as taking individual protective strategies in education, such as using non-polluting cooking stoves in the home. Occupational dust and chemicals can also be achieved through education, and that includes legally mandated airborne exposures in the workplace, education on exposed workers, industrial managers, healthcare workers, PCP, and legislators. We want to educate employers, workers, and policymakers to implement, monitor, and enforce strict legally mandated control of any kind of airborne exposures. In the pathophysiology of COPD, we have a couple of things that happen. We have airway trapping and airflow limitation. We have impaired gas exchange. We have mucus hypersecretion, and in very severe cases, we may have pulmonary hypertension. In the air trapping and airflow limitation, we have inflammation, fibrosis that causes air trapping during expiration and results in hyperinflation of the lungs. In impaired gas exchange, the peripheral airway obstruction combined with the ventilatory muscle impairment leads to CO2 retention, which in turn causes hypoxemia and hypercapnia. In mucus hypersecretion, we have mucus metaplasia, increased number of goblet cells, and enlarged submucosal glands, which irritates the lungs and produces a cough. The cough is commonly present in chronic bronchitis, but is not always related to airflow limitation. In pulmonary hypertension, we have hypoxic vasoconstriction of the small pulmonary arteries that causes structural changes such as intimal hyperplasia and smooth muscle hypertrophy and hyperplasia. Typical symptoms of COPD include shortness of breath, sputum production, and chronic cough. Symptoms can be further broken down by stages of COPD. In mild COPD, we see symptoms of chronic cough and sputum, and these symptoms can often be present for years without causing any kind of airflow limitation and are usually associated or attributed to the aging process or physical deconditioning by the patient. In moderate COPD, we see dyspnea with exertion and daily activities. This is when most people seek medical attention. Their symptoms are either exacerbated by an acute upper respiratory infection, and at this time they seek an attention of a doctor. In severe COPD, we have cough and sputum production, and the shortness of breath worsens, and symptoms of possible complication can also develop, such as respiratory failure, right heart failure, weight loss, and arterial hypoxemia. In very severe COPD, we may have wheezing upon auscultation and chest tightness. The chest tightness is described as poorly localized. It's muscular in character, and it may be caused by isometric contractions of the intercostal muscles. Critical assessment, finding, and treatment in this patient population is listed below. The assessment includes cyanosis of the mucous membranes, and that's usually seen in the mouth. We can also see clubbing in the fingertips, as well as a capillary refill of over 3 seconds, and that's due to the decreased oxygen that's delivered to the extremities. A barrel chest is seen in patients that have hyperinflation and air trapping. Pursed sleep breathing is due to the efforts in trying to expel the retained CO2 in the lungs, so there's a longer expiratory phase when patients are breathing. Patients can sometimes also be slumped over just to help the lungs expand and get rid of that extra air in the lungs. We can also see ankle edema and lower leg edema in patients that have developed complications and have right-sided heart failure. You can also find reduced breath sounds when you auscultate and wheezing and crackles in the lung. Treatment for the COPD patients includes pharmacological treatments to control their symptoms, and to reduce the frequency and severity of their exacerbations, to improve their health status and improve exercise tolerance. The most common medications are bronchodilators such as the beta-2 agonists, the anticholinergics, the methylxanthines, and also a combination of these therapies. Another one is a glucocorticosteroids that can be inhaled or can be used as short-term therapy for patients that are admitted with an acute exacerbation of COPD. Another one is a phosphodiesterase 4 inhibitor that can be used also in the COPD population. Many of these COPD patients, especially during the progressive stages and stage either 2, 3, or 4 of COPD, are usually on a combination of these therapies, just trying to help control the symptoms and to give them that better quality of life. There are many lab and diagnostic data that can be collected in COPD patients to either diagnose or measure the severity of the lung disease. Spirometry is usually the gold standard, and it's used to diagnose and measure the decline in a patient's lung function. It's considered one of the least invasive procedures, such as the patient just has to breathe into a tube as it measures the lung volumes. You can also obtain arterial blood gases and measure the respiratory failure that way. There's also CT and ventilation perfusion scanning, and that's used to visualize the airway and parenchymal pathology. And it's usually just used for surgical evaluations, and it's mainly due to the cost of the test. The hematocrit, anything over 55% can indicate polycythemia in the presence of arterial hypoxemia. A low hematocrit level also indicates a poor prognosis in patients on long-term oxygen therapy. Sleep studies can also be indicated in patients who have a possible sleep apnea problem. And there's multiple exercise testing that's available to measure the exercise capacity of these patients. COPD can be extremely taxing on a patient's physical status as well as spiritual and emotional well-being. There have been holistic therapeutics as well as complementary and alternative therapies to the management of COPD. Smoking cessation programs, the goal for them is to stop the progression of the disease and help to keep the symptoms of COPD under control. Pulmonary rehabilitation, their goals are to reduce the symptoms, improve quality of life, and optimize the patient on their physical capacity to complete their daily activities so they're not so deconditioned. It increases peak workload by 18%, increases peak oxygen consumption by 11%, and endurance by 87% of baseline. The Feldenkrais Mythos is an 8-week program, and it focuses on mind, body, and spirit interaction to help patients develop strategies for movement so they may continue doing their daily activity using the least amount of energy with still maximum effects of their movements. This is perfect for patients that have shortness of breath with activity. Traditional Chinese medicine uses herbs and with medicinal properties to relieve symptoms of COPD. This has to be taken into consideration when patients are on therapies, pharmacological therapies such as bronchodilators and other inhalers, because there may be a drug-drug interaction. Outcomes for health and wellness for the COPD population includes decreasing symptom severity for the patient, stopping the progression of disease through smoking cessation programs, increasing the quality of life of patients with the symptoms they already have, improving exercise tolerance so patients don't have to stop their daily activities, improve health status through holistic or pharmacological therapies, prevent and treat complications and exacerbations, and reduce the overall COPD mortality. Management of the COPD patient requires a team-based approach of several different disciplines. Communication between these disciplines is required, and a variety of treatment strategies is required for the overall treatment of these patients. We also need the commitment from all the clinicians to be supportive of the patient as the disease progresses through their lifespan. Providing nurses with the tools presented in this presentation enables us to have the knowledge, to have the resources available to advocate for our patients, and to make sure that they're receiving a full spectrum of quality of care and that it's addressing their mind, body, and spirit health outcomes. Thank you for your time, and I hope you learned during this presentation.